Good afternoon, everyone. I hope you and your family are doing well. My name is Dr. Raquel Romero, and I'm going to be the facilitator for the ECHO session today. And thank you for making the time to join the Comunidad Long COVID ECHO series. This project is a comprehensive long COVID care for underserved communities. This is an innovative delivery and dissemination model project, also known as a Comunidad. At the UT Health San Antonio, our post-COVID-19 recovery clinic serves San Antonio and a broad and large rural region in South Texas, and this community faces significant health disparities and barriers of care, and misinformation about the long COVID and the diet remains widespread. To address those challenges, the Comunidad Project, a 5-year initiative funded by the Agency of Healthcare and Research and Quality, and the Comunidad Long COVID ECHO seeks to improve and expand the long COVID care through innovative, sustainable models in our region and beyond. If you are new to the ECHO platform, ECHO stands for Extension for Community Health Outcomes, and it serves as a virtual telementoring platform especially designed to create connections between communities and subject matter experts. Each session begins with an introduction, and then we have a didactics and case presentation. During the case discussion, members of the community will present a real-life patient cases to address their health needs. Therefore, to ensure privacy, no personal health information is allowed to share at any point in these sessions. And I want to take a minute just to ask if you have a case to present, please reach out to us. We're always looking for ways that we can help our community to understand more about the long COVID. So if you have a case, this is a very good place where you can be connected with experts of matter in this area. And a few housekeeping reminders. Kindly, I would like to ask you if you please enter your name, your affiliation, and the email and the chat. So it's going to be for our attendance records. And if you have any issue with the connection, we have an IT person ECHO, so you can send a message to her, and she's going to be helpful during the session. Thank you so much. With that, I would like to then now start with an introduction from our team, and I would like to start with Dr. Sabat, who is also co-presenting the case for today.
Thank you, Dr. Romero. My name is Joel Sabat. I'm a general internist. I'm one of the PIs on the AHRQ Long COVID grant at Direct the Reach Center, and I'm happy to be here today.
Thank you so much, Dr. Sabat, because you're presenting the case, as well as Dr. Tegarian, who is also the didactic presenter, a case presenter today.
Hi, everybody. My name is Roy Tegarian. I'm a clinical psychologist on the Long COVID clinic here at UT Health San Antonio, and I'll be presenting the didactic and partnering with Dr. Sabat on the case presentation.
Yeah, thank you so much. And again, if you have a case to present, please reach out to us. We would like to hear from our community and how you facing up this situation and how you're taking care of your patients. Thank you so much. Finally, we have you and the audience. Thank you so much for making these sessions possible. And I would like to say that ECHO is all teach on learn environment. So we encourage you to participate in a conversation today and raise any question and use the chat. But also I see Dr. Monica Verduzco. Dr. Verduzco, we're doing the short introductions to the audience. Will you please introduce yourself?
Yes, hi, Dr. Monica Verduzco Gutierrez. I am a PM&R physician here at UT Health. I'm the medical director of Long COVID Clinic, and happy to be here today.
Thank you very much, and thank you all that make this possible. So with no more from my end, I will ask to pass this space to Dr. Tegarian for the didactic presentation. Thank you so much.
Okay, great. Let me see. Kito, are you sharing my slides yet, or?
Yep, it should be up.
We see that. Mm-hmm.
Oh. I don't see them. Okay, well, I can't see the slides, but I'll trust that they're there. Okay. Hey, everybody. A friendly reminder, my name is Roy Tagrarian. I'm a clinical psychologist with the Long COVID Clinic here in UT San Antonio. Um, One of the things that is really important is understanding that people suffering from chronic illnesses such as long COVID can really benefit from psychological services. And the leadership of the Long COVID Clinic here had the wisdom and understood the need that patients are being treated by the physicians, but also can benefit from psychological services. One of the things that we're going to talk about here in the presentation is the mind is very, very powerful and can influence how the body reacts to stress and high cortisol levels, and how there is research in with CBT and ACT for chronic illness, how that has demonstrated a reduction in stress, which can help reduce inflammation in the body. So it's really an interdisciplinary approach that we're taking to treat patients with long COVID. And I think we're seeing some positive results from that. So the learning objectives for today, by the end of the presentation, oh, I'm sorry, by the way, I have nothing to disclose. That aside, learning objectives for today is we're going to define long COVID and identify common psychological and behavioral presentations. We're going to explain the role of psychological services in long COVID care. We're also going to describe how ACT, acceptance and commitment therapy, and CBT for chronic illness, and CBTI, cognitive behavioral therapy for insomnia, um, how those approaches can help patients suffering from chronic illnesses, including long COVID. And then we're going to identify practical treatment targets, such as pacing principles and clinical cautions that we should be aware of. What is long COVID? So I'm on slide 3. And you can see the definition here. This comes from the World Health Organization. I'm not going to go ahead and read that. You can certainly read it. But one of the key things here to notice is the second paragraph down, that there is no minimum number of symptoms required for the diagnosis. And then symptoms involve different organ symptoms, and clusters have been described. One of the common things in the work that I think those of you that are treating long COVID and from the psychological services perspective is, while there are some commonalities within the symptoms that people are experiencing with long COVID, there are also some key differences. As an example, many of the patients that I'm treating do not have symptoms related to loss of taste or smell. Some of them do, but most don't. So there are different presentations, which makes treating long COVID really challenging for the physicians and for psychological services as well, because we're trying to figure out what symptoms they have and how best to treat those. The other thing is the definitions are really important. They fluctuate. They change from time to time in quantity and quality. So, if you think about symptoms in kind of a wave format, so hopefully this analogy lands. Um, Most of us have been to the ocean, and most of us have been knocked over by a wave. And it winds up moving us 30 feet from where we were when we got hit by that wave. And then there's kind of mild waves that knock us back a few steps. And then there's I'm sorry, those are the moderate waves. And then the mild waves are the ones that kind of hit us. We feel it, but it doesn't really move us. And patients with long COVID experience all 3 of those waves. And it's unpredictable which wave is going to hit them on what day. You could have a patient that's had a really good week, and then one day they just wake up and they're hit by that severe wave, and their symptoms increase in quantity and severity. The other thing is that relapse, so the return of the disease manifestations after periods of improvement. So it's kind of a roller coaster for these patients. They do well, and then sometimes out of nowhere, these symptoms return for them, and it creates stress for the patients because there's no clear path forward for them sometimes. They're always, oftentimes, they're hypersensitive to different pains or different symptoms, and they're anticipating a severe wave is going to hit them, a severe symptom wave. And that affects the way they think about things, that affects the way they kind of approach life and their activity level. And the last part of this is that two or more symptoms that are related to each other that occur together. And they are composed of a stable group of symptoms that are relatively independent of other clusters and might reveal specific underlying dimensions or symptoms. The physicians that are in attendance today can certainly speak more to the physical symptoms, the physiological symptoms, the neurological symptoms that are occurring with patients that are suffering from long COVID. And hopefully that'll be part of the discussion when we get to the case presentation a little later. So slide 5, please. So the patient clinical presentation is really important to understand. Long COVID is heterogeneous, right? We just don't know how they're going to show up. And patients may experience or present with combinations of fatigue, post-exertional malaise-like symptoms, pain, dysautonomia type complaints. And then what's bolded in the slide is really the area in which I practice, and that's anxiety, depression, insomnia, cognitive complaints, grief and loss over functioning, and loss of identity. That loss of identity is really, really critical in the work that we do here with psychological services that I'll speak more to in just a minute. Slide 5, please. Why psychological services matter. So slide 6. So psychological treatment does not mean symptoms are imagined in the patient. I hear patients felt like they've been gaslit for many, many years related to long COVID with some clinicians, and of course, no fault of the clinicians. We just didn't know a lot about COVID at the time, long COVID at the time. Their symptoms were just not believed. And they were kind of told to just power through it and figure it out. So the patients didn't really feel like they were heard oftentimes, and often they heard from treating clinicians that these symptoms are just all in their head and they'll be fine. So kind of the way to view psychological services is it's also a therapeutic. Like medications, frontline providers, physicians, nurse practitioners can suggest as part of the patient's treatment. And we'll talk a little more about how there's research that shows that that CBT and ACT for chronic illness can actually help patients reduce psychological distress and improve kind of their overall quality of life. So one thing I wanted to talk about is the expectancy effect. So simply put, the expectancy effect has been widespread and extensively researched psychological phenomenon. It happens when one's belief or expectations about a person, event, or situation influence one's behavior in a way that makes those expectations come true. So it's as if the mind sets the stage for what's going to happen. So the expectancy effect can improve acceptance, behavioral activation, psychological flexibility, increase coping, and a reduction in physical symptoms or severity. It doesn't eliminate them, but it helps reduce the chronic stress or the rumination related to their chronic conditions. And there's a saying here that goes, as goes the mind, so goes the body, and as goes the body, so goes the mind. You can put those in any order you want, but the idea here is that we know that based on the research of the expectancy effect, that if somebody expects a negative outcome, chances are it's going to be a negative outcome. If somebody expects a positive outcome, there's a greater chance that they'll experience a positive outcome. Is there research that supports that? Yeah, and the research is extensive. So if you're really curious about the expectancy effect, there's plenty of research to go and research that. There's a couple of references down here at the bottom that if you want to look at the expectancy effect, they're there for you. So psychological services targets the real psychological consequences of long COVID. And I stress the real because they are real. People not only suffer physically, physiologically, neurologically, but they're also suffering psychologically. And that shows up in distress, avoidance, fear, demoralization, sleep disturbance, cognitive changes such as difficulty concentrating, difficulty engaging in reciprocal conversation, the loss of routine, the loss of their identity, reduced activity tolerance, and difficulty adjusting to an unpredictable condition. And this aligns with the current models of long COVID care, which emphasizes symptom management. We all wish there were a cure for long COVID, and hopefully that's coming. Rehabilitation, self-management support, and a multidisciplinary treatment. And I think I humbly say that's what we're doing here at UT Health San Antonio under the leadership of the Long COVID Clinic. So next slide, please. So the targets for psychological treatment. So we target anxiety and the catastrophic interpretation of symptom flares. So one of the things that we commonly hear in psychological services is when somebody has a symptom flare, they feel like they're returning back to their earlier baseline level of long COVID before it was being treated by physicians and by psychological services. It doesn't matter how minor the pain is, it doesn't matter whether it's mild symptom increase, it activates anxiety for them, and they engage often in catastrophic interpretation and catastrophic thinking, which we know is a cognitive distortion in CBT. But it's real for them because they've lived this for a long time, and they have reason to believe that when there's a symptom flare, that their health is at risk. So it makes sense. They're also experiencing depression, grief, and hopelessness. One of the things that I continue to hear with the long COVID, by the way, these are not shameless plugs for what we're doing here at UT Health. So my apologies if it's coming across that way. I'm just giving you real patient feedback that what they feel like we're doing well here is we're validating what they're experiencing, and we're providing them with some hope that we can help them improve their lives, even if it's just a little bit. And hope is really important when you're dealing with a chronic illness. The grief we're going to talk about in just a minute here, but insomnia is a big issue and irregular sleep patterns. I continue to hear from most of my patients that they have difficulty sleeping, both trouble falling asleep and disturbed sleep, so trouble staying asleep. Unhelpful activity cycles leading to overexertion. This ties back to individuals with long COVID remembering what they were prior to getting long COVID, and they think they're still able to engage in activities at the same level that they used to. And what happens is they overexert themselves, and then they are fatigued for a day, 2 days, 3 days after they engage in these activities. So one of the things to help them with is understanding that, okay, you can still do the things you used to do. It may just look a little different and may take a little longer to get done. And that also inspires hope. This other one is really important. Reduce self-efficacy, self-confidence, and self-esteem. I'm gonna save that. There's a slide coming up here that gets into a little more detail. But the headline with that one is that individuals have lost confidence in their ability to do things and believe in themselves because their bodies have changed. They're no longer able to do some of the things that they used to do or that they valued. And that has affected their sense of self, their self-confidence, their belief that they can do things, their self-esteem, their belief that they are valuable even with this chronic condition. And then the self-efficacy, the ability to actually do a specific task. Many of the patients are suffering from social isolation due to emotional and physical avoidance. One of the common themes we hear there is that their families or their friends or their providers don't believe that they're suffering from a chronic condition, and they think it's made up in their head. So instead of hearing that every interaction with their friends or family, what they wind up doing is they socially isolate. They emotionally avoid conversations related to this topic. And they wind up taking it to sometimes extremes by cutting out family and friends that they used to enjoy spending time with. However, that also makes sense because, you know, when you're engaging with family and friends and you keep hearing that it's all in your head, at some point the invalidation becomes too much, that it's just easier to not engage than to spend any psychological and cognitive capital on trying to get people to understand this. Difficulty re-engaging in values-based living. We'll talk about that in just a minute. And this one is really important: identity disruption and new identity formation. If you think about patients that were highly active, had a high level of cognitive ability, adaptable, a lot of psychological flexibility, we can call them kind of version 1.0. And often what happens with patients that are experiencing long COVID is that they're still trying to hang on to that version of them, that version 1.0. And distress sets in when they're trying to be version 1.0 and they haven't yet decided to engage in really acceptance and committing to creating a new version of themselves. And that's hard for people to do. And you know, that's where the psychological services comes in, particularly acceptance and commitment therapy, to help them form their new identity, given their values and the constraints that long COVID places on their lives. Relationship disruption and estrangement. I think I mentioned that earlier. I have patients that struggle with their marriages because their spouses don't understand the condition. Because long COVID, for the most part, is invisible. It's internal in the body. So when somebody has the flu, right, you can see the external symptoms of that. Most people have had the flu. People can relate to when other people have the flu. But if you've never had long COVID and it's invisible to the people that you love, that you care about, that you interact with on a daily basis, they don't see the internal battle that's going on in your body. And that makes it really difficult for people to understand that, yeah, you know what, I'm having a bad day today. I can't get out of bed. And you know, their family will look at them and say, well, you look fine to me, right? Get out of bed and let's get going here. And that creates a lot of relationship disruption and estrangement. Acceptance and commitment. So, you know, accepting that you have this new condition, accepting that, you know, you're going to have negative thoughts and negative emotions around this condition that you have, and that's okay. it's okay to let your mind kind of drift towards, oh, I wish I didn't have this. I wonder what my life is going to be like. I want my old life back. It's okay to accept those thoughts. The key there is, though, to not drop anchor and stay in that space. So accepting that this is the condition that you have, accepting that you're going to have some negative thoughts and emotions related to it, accepting that you're going to have waves of symptoms, mild, moderate, severe, that are going to hit you. But then there's the commitment part, and that is committed to action, committed to treatment adherence, committed to engaging in healthy diet and exercise as able, committed to living one's values. And again, one can live one's values even with a chronic condition. It just may look differently for them. It might be a little slower, and it might just be virtual instead of in person, right? So people can still live committed to their values. Stress reduction, we're going to talk about here in just a minute, and then psychoeducation. Next slide, please. So this is really key to establishing a therapeutic relationship. And I believe this is true not only in the psychological services domain, but also in the physician and nurse practitioner domain. And so it starts with validating the patient's symptoms and impairment. Avoid suggesting symptoms are purely psychological. Clarify that treatment aims to improve coping, functioning, sleep, and distress reduction. Avoid simplistic push-through-it messaging, and use collaborative, non-dismissive, and pace-informed approach. One of the things that patients continue to tell us, I don't want to speak for the physicians here, but I think it's pretty common, is that they've heard from previous providers that their providers didn't do these things. They didn't validate the patient's symptoms or impairment. The way one patient described it to me was, they said, Roy, imagine driving your car and it doesn't feel right. It's making noises. It's riding the road rough. When you hit the brakes, something doesn't feel right. And then you take it into the mechanic, and the mechanic test drives it. And it's like, they can't find anything. And then, of course, you get in the car and you drive home, and then all of a sudden, the car starts making those noises again. That's one way that a patient described their experience with providers early on. So here's a couple of examples. I'm on slide 9. So here's a couple of examples of approaches. And this is through the validate approach and the treatment approach, or through the lens of psychological services, although you could probably take a version of this and apply it to the physician and nurse practitioner approach. So the validate approach, your symptoms are real. Many people are suffering from long COVID just as you are. We may not be able to control or improve every symptom directly, but we can work on reducing suffering, increasing values-based living, improving sleep, and help you live more effectively within your current limits. The essence of that is hope, and helping people understand that you still have a life worth living, even with this chronic illness. Whenever I say that to patients, I can often see kind of their shoulders just relax. It's like, okay, somebody's finally getting it. Somebody's finally helping me understand how to think about this, right? And I think the physicians do a really nice job with this as well, is helping people understand that, hey, we're going to do the best we can, and we're going to figure this out together. I've heard that from patients as well. And the treatment approach, this is really important for those of you that are physicians or nurse practitioners or providing psychological services. It's really important to land these 2 points. There are 2 important parts of our work. The first part is to get you to do everything possible to improve your health. which includes cooperating and engaging with your medical team, improving and looking after your diet and exercise, medication adherence, and addressing treatment fatigue. The second part is to get you doing everything possible to make your life as good as it possibly can be right now, given all the difficulties imposed by your long COVID diagnosis. We're not minimizing what they're going through. We're not invalidating what they're going through. We're inspiring hope that even with this condition, even with the bad days you're going to experience in the future and the bad days you've had in the past, we're still going to get you there. Hey, I know I'm running along here, so we're almost there. So acceptance and commitment therapy is especially useful when dealing with persistent and fluctuating symptoms that do not fully remit. There's research that supports this. And ACT focuses on psychological rigidity and negative internal experiences. So one of the benefits to ACT is that it helps patients develop psychological flexibility. Psychological flexibility has been shown to be an effective way to handle chronic illnesses. And it really stresses the importance of acceptance and committed action, so behavior, committed to living one's values. We'll skip the last 2 points there. So here's what ACT for long COVID targets. So it targets cognitive distortions such as my life is over or I can't do anything now. It targets experiential and emotional avoidance, identity loss, grief after loss of prior functioning, stress management, treatment fatigue, withdrawal from values-based living, and all or nothing cognitions and behaviors around activity and rest. And here are the interventions for long COVID, ACT interventions for long COVID. So values clarification and identifying values-based roles and activities to engage in, acceptance of discomfort and uncertainty, acceptance of negative cognitions as temporary and transitory, behavioral activation based on values, and sustained committed actions aligned with current capacity. So getting people to understand that they still have the ability to do some things, it's just going to look and feel different for them. And then identity reformation, so helping people establish a new identity given this chronic condition. So CBT targets for long COVID, so we'll jump from ACT to CBT. So the wrong approach when discussing CBT is it should avoid telling patients that their symptoms persist because their illness is all in their head. That never works. The right approach is for the frontline providers, the physicians, the nurse practitioners, is maybe a way to communicate to your patients who are considering psychological services or are resistant to psychological services, is you can say something to the effect like thoughts and behaviors can influence coping, symptom severity, distress, even when the underlying illness is real. So here are the targets, the CBT targets for long COVID, and there's some examples there. I won't spend a lot of time. You can go ahead and read those. But what I really want to do is focus on the right side of the slide, lower shattered self-esteem. So, here's a simple definition of self-esteem, one's overall sense of self-worth. And the core question anybody asks related to one's self-esteem is, am I worthy? And an example is, I'm valuable even when I'm ill. So this is the cognitive restructuring part of CBT, is that you're still valuable even when you're ill. It doesn't change your value in any way. You're still a human being. You're still worthy of respect and care. So the next one is lower shattered self-confidence, belief in one's ability to handle situations. One of the questions, or the core question that I often hear patients ask without them actually explicitly or overtly asking it is, can I handle this? And one of the things we do is we help people say, yep, I can figure this out. I can do this. And then the self-efficacy question, belief in one's ability to complete a specific task. Can I do the laundry without being exhausted for 2 days? right? So can I do this specific thing? And helping them understand that I can complete this task. I just have to pace myself. I'm not going to spend a lot of time on this slide, but I'm going to summarize it. So we know that chronic stress produces cortisol at levels that create inflammation. And as the physicians and the nurse practitioners treat the inflammation within the body through medication and other means, one of the key things in CBT and ACT is to help patients manage chronic stress management, stress reduction techniques. So it's a coordinated approach where the physicians are treating the inflammation through their means, and through psychological services, we help them develop stress management techniques. So together, we're bringing down the inflammation. I can't see myself, so hopefully you see my hands coming down here, but that's the idea behind this. And then finally, CBT interventions for long COVID. So psychoeducation on stress, stress management, behavioral activation, PACed, of course, cognitive restructuring. So cognitive restructuring, simply put, is restructuring somebody's thoughts related to negative attributions or negative self-evaluations or negative interpretations. Activity tracking. So this is one of the things that I have seen success with treating my patients, is we engage in these micro experiments. And the idea here is to identify the limits and overexertion patterns. So for example, somebody was waterproofing their wood fence, and I think they're 15 slats long, and she would get exhausted after just staining 15 slats. So what we said is, okay, let's start at 7 and see what happens. And we found that the limit for her was 8 slats. If she did 9, she became too tired. So she now knows that, okay, the next time I need to paint the fence or stain the fence or waterproof the fence, 8 slats. So she's still capable of doing it. It just looks a little different. It's going to take a little longer, and she needs to know where the limits are. And when they start to engage in these micro experiments, they're starting to understand, okay, so I'm still capable. It's just going to take me a little longer to do some of these things that I was able to do like that in the past. Medical and medication adherence, so making sure that they're sticking to their appointments, they're conserving their energy, they're taking medication as prescribed, and advocating for themselves. Yeah, so sorry for the abrupt ending. So thank you. And then here are the references related to everything I've covered. So is it okay to jump into the case presentation? Or
Yeah. Just me ask the audience if they have any question, any comment in regards to the presentation. I would like to say that it's really sad to hear that when you mentioned the providers, family members, the people around, they don't believe what I do have. So what you're doing is wonderful. It's marvelous for them. Like you say, inspiring hope for those that are suffering for chronic conditions. Thank you so much for walk us through that and the therapy that they may receive. Thank you so much, Dr. Traganen, for this.
yeah, sure.
So yes, we can go to the case if you want.
Okay, so Dr. Sabat and I are going to kind of tag team this, but here's what we have. So the patient is a 60-year-old male who's married and has 2 children. The children are aged 12 and 13 years old. Their housing is stable. Employment is unstable at this time, and their annual household income is less than $100,000 a year for a family of 4, living in one of the most expensive parts of Texas. The patient had at least 2 prior COVID infections. However, the patient did not test regularly when sick for 5 years. So the patient has kind of had this chronic illness since the beginning of COVID, but he wasn't regularly testing. So we only know of 2 confirmed COVID infections. And those 2 confirmed COVID infections were in February of 2021, in January of 2026. Vaccination history, he got the Johnson & Johnson vaccination in early 2022. The patient was not hospitalized for COVID, but for post-COVID disease onset, which we'll talk about here in just a minute. Pre-COVID comorbidities, he has a history of smoking. He recently quit in the past few months. However, he's been a smoker for decades, and he has a history of substance use. Overall, he was mostly physically healthy. He is a retired school teacher who engaged in roofing construction after retirement. So no physical labor while a teacher, but engaged in roofing work, which is highly physical after he retired from teaching. Long COVID symptoms experienced, so post-exertional malaise, fatigue, and brain fog. And then he also had some GI symptoms. It's unknown if the long COVID GI symptoms exist as it relates to long COVID, or if it was the onset of UC, which he is now diagnosed with. So the patient has developed a new medical condition after COVID. He's got UC. He's had an acute flare twice a month post-COVID infection. He's not able to perform activities of daily living, although he's getting there with his UC treatment regimen. Return to pre-illness employment partially. He's been out of work for 1 to 2 months during acute flare of UC, returned partially to work, but cognitive issues limiting ability for desk work, sales, developing marketing plans, written communication, and unable to return to physical labor at this point, limiting income. So he was transitioning with the company he worked for. He was a roofer, and he was hoping to transfer into or transition into sales and support. And he's experiencing cognitive challenges that are precluding him from being able to effectively do that work. So COVID infection in late 2026, no hospitalizations. He's, let's see here. Let's jump down to March and April of 2026. Patient presented to the emergency department following a 2 to 3 weeks of diarrhea, nausea, vomiting, fatigue, brain fog, and cognitive slowness. The emergency department visit on 3/1 tested for C. diff, and it was negative. Mostly dismissed the case as dehydrated. He was given a prescription for antibiotics and IV hydration, and he was not admitted to the hospital. Emergency department visit 2, about 2 to 3 days later, following no reduction in previous symptoms, the vomiting, the diarrhea, and significant weight loss. He lost about 20 pounds. Imaging, more thorough workup, diagnosis with UC. And he was given oral steroids, and he was discharged in less than 24 hours from the hospital. Here we are about 10 days later, emergency department visit 3, 7 days later, following no improvement in symptoms, he was admitted to the hospital. The admission lasted 3 days, and he was given IV steroids, clear diet, and he was discharged with oral steroids. GI follow-up for outpatient. And then he went back to the emergency department at the end of March, 3/31, after attempted prednisone and continued vomiting, diarrhea, blood, and minimal urine output. He was admitted to the hospital for 14 days. And he was given an IV steroids, worked way up to a clear diet and then a full diet, and started UC medication. And then he was discharged for maintenance. He was never assessed for long COVID or long COVID-induced UC admission. So how about we stop there? And here are the questions that are being proposed. I guess there's one last point. He was highly active prior to long COVID, so or I'm sorry, before this condition. So he used to be really active. He's feeling some psychological distress related to not being able to engage with his young boys, which is really hard for him because he was highly active and he wants to be part of the boys' life. So one of the questions that are being posed is, what are some of the recommendations for primary care or GI doctors discussing COVID connection to new diagnosis or potential long COVID? So I think the question's getting at, could there be a long COVID connection to these symptoms, and what recommendations are there for primary care or GI docs to be able to have those conversations with the patient? And I guess I'll defer to Dr. Savat to kind of facilitate that.
Yeah, yeah, thanks. And we have Dr. Gutierrez and Dr. Brode also. Please weigh in here. I don't know, as you intimated, whether these GI symptoms were a manifestation of long COVID, years later, or ulcerative colitis. Do we know if the patient had a colonoscopy?
It doesn't say he did.
Okay.
I don't see that in the.
You would pretty much need that. Because it's unusual. I mean, it's most common in younger people. It can happen in older adults as well. But I don't know. I mean, he was seen by GI, so I'm assuming they got the correct diagnosis there. But I think in terms of GI symptoms in general, they are fairly common with long COVID, so it's certainly possible. I don't know, Maria or Mike, Monica or Mike, do you have anything to add?
My add is that, like, I would say maybe they think that there is probably GI part of long COVID in some of the phenotypes, and maybe 10 to 20% of the patients will have GI symptoms from long COVID. They've found that, the viral remnants of COVID that you find in people's bodies are in some of the GI, in biopsies of the GI system. So we know there's something there that's driving inflammation, autoimmunity, everything else that happens with long COVID. So yes, but do we always have good tests for looking at that? Of course, we don't. Would at that case, would want to make sure that they've had a colonoscopy and look for things that are more easy, diagnosable and treated. I mean, this person's already has some kind of autoimmune disease because they're on Tremfya, and I always feel like autoimmunity begets other autoimmunity, so they should look for some kind of IBD anyways. But
I assumed that was for the ulcerative colitis, because
he has ulcerative colitis.
well, we think, I mean, that was
Oh.
just diagnosed
Oh.
recently, right?
Yeah.
Yeah. When I first saw that medication, I asked Dr. DeGrarian, is there a history of like psoriatic arthritis?
Right.
No, but it's a medication for ulcerative colitis, so that's what I'm going with. But yeah, I don't know. So I don't know if there was a previous history of autoimmune disease on top of on top of this.
Yeah. And you think the GI is the worsening of the ulcerative colitis? Because the other thing is I've seen COVID and long COVID exacerbate underlying illnesses too. And it's just an exacerbation from all the inflammation that's going on with him having had COVID.
It could be.
Yeah.
Dr. Broad, do you have any comment?
Yeah, I'm going to echo what Dr. Savad and Dr. Verduzco said. I think pattern recognition, my experience is that, usually most of the long COVID symptoms will begin within 4 to 8 weeks following the infection. A lot of the neuroinflammatory features, dysautonomia, so GI dysfunction will usually start within that time. And I've seen it kind of crescendo within the first year, but I think most patients, and the research says that those symptoms will get better, if not start to wane a little bit in severity, although the fatigue, post-exertion malaise, neurocognitive impairment is usually what persists. And so on pure pattern recognition, this is what keeps me up at night of a new problem year or two later in the setting of long COVID is I think a timeout to not necessarily automatically attribute it to long COVID, but to get the full workup. And this is one where I'd say on that time course alone probably makes attribution to long COVID as a rule out diagnosis, but it sounds like that's what's happened.
Thank you very much. And how can be the recommendation? How can be recommended to primary care? One of the questions to discuss COVID connection to the new or this diagnosis. How we can
Yeah. So I would just say, that's kind of a thorny issue. What do you attribute to long COVID and what do you not attribute to long COVID? Right? Because long COVID, as we all know, encompasses hundreds of symptoms. And so, oh yeah, that headache, that's long COVID, that shortness of breath, that's long COVID, but it may not be. And likewise, something you don't have to work, you might go in the other direction, right? So patient comes in with shortness of breath. Oh, that can't be long COVID, right? But actually it could be long COVID, right? So we as clinicians have to figure out how much of a workup to do and what to attribute things to.
Yeah, and then also along with that is what can be the recommendation for helping patient and family with behavioral for like understanding fatigue when they are not currently considered like a long COVID, how we can help to understand that. Is there any comment?
Could I get back to Dr. Degrarian's didactic presentation for a minute? That'd be okay. First of all, thank you very much for that. It was very clear. You offered a lot of pragmatic and approaches and tips. Question for our audience. So, we're learning that mental health problems are very common with long COVID. But we also know that there's a shortage of mental health providers, particularly in rural areas. And so I wonder if people from our community, if they run into this issue with long COVID, that, hey, this patient has trouble coping or could use some mental health expertise, but I don't have anybody to send them to. Have we seen that?
Dr. Savada, I'll share a story that is not related to rural, but I had a patient yesterday, a new patient. She lives in Houston and she could not find providers there who understood long COVID, a physician who could treat long COVID, or a psychologist who understood long COVID. And she kind of threw up her hands and gave up until she found out about the long COVID clinic here in San Antonio. So I don't know that it's even exclusive to rural settings. I think it's major metropolitan areas where they just can't find the quality of care that is needed for long quality of care or even understanding of it. So,
Right.
yeah.
Another comment, thought from the audience in this regard?
Yes, I have just another that, we really appreciate what Roy has been doing for our patients. We've just seen it really as being necessary. And the other thing is that his services can be done virtually. So that means if patients are not local to our community because they have to travel, because we see patients from all over the state, that it's great that he can still do, virtual reach out to them and do the cognitive behavioral therapy. And I know sometimes cognitive behavioral therapy gets a bad rap, but we're not saying that, again, and we bring this to our patients. You have something really going on pathobiologically, and we just need to put your mind frame in the right, put yourself in the right mind frame to deal with this new chronic condition.
Yeah, so we'll say that expectancy effect, right, Dr. Tagaran? Like,
Yeah.
did you expect something positive?
Yeah, exactly. The expectancy effect is extremely powerful. So if we can get people, if we can inspire hope, if we can inspire people to live their values, if we can help people understand that they still have a life worth living, that can go a long way in the way they approach their chronic condition, the
Very
way they
important.
engage in the medical system. So.
Yeah, that's very, very important. And I hope through this discussion and this presentations, we get some points that we can learn and apply in our daily life, and also with our patients when we have those situations. And the validation that you said, so important. Validate, right? This is important for everyone, right? Everyone wants to be heard and understood. So thank you so much for giving us this point of view and the didactics. We took a few more minutes from the hour, but I want to say thank you so much. Is there any final thought, Dr. Sabat and Dr. Bertusco Gutierrez or Dr. Broad? Any another comment?
Just that, as we said that, we've been saying throughout this series that long COVID is common and it's highly variable in terms of its presentation and its course, but can be very debilitating. It can affect, physical function, mental health, social function, role functioning, every aspect of one's health status. I do want to leave 1 or 2 minutes so everybody can fill out an evaluation. And also want to encourage our audience members to submit cases to us for future echo sessions.
Thank you so much. And please check your emails for the future sessions that we planning on having, and think about the case that you can present here. There are so many stories out there that we want to hear, and ECHO is OT online environment, so we invite you to be part of this learning community. But with that, and thank you so much for your participation, comments, and I hope, Dr. Tegaren, all your questions were answered from today's session, and I hope to see you next session, and just have a wonderful rest of the day. Thank you very much.
Thank you.
Thanks, everybody.
Thank you.